Hello and welcome to our video on Pompe disease. Glycogen storage disease type 2, also called Pompe disease and formerly known as GSD-LLA, is an autosomal recessive metabolic disorder which damages muscle and nerve cells throughout the body. It is caused by an accumulation of glycogen in the lysosome due to deficiency of the lysosomal acid alpha-glucosidase enzyme. GSD2 and Danon disease are the only glycogen storage diseases with a defect in lysosomal metabolism, and Pompe disease was the first glycogen storage disease to be identified in 1932 by the Dutch pathologist J.C. Pompe. The buildup of glycogen causes progressive muscle weakness, myopathy, throughout the body and affects various body tissues, particularly in the heart, skeletal muscles, liver, and the nervous system. 1. Discovery of Pompe disease. Johannes Cassianus Pompe identified the disease in 1932. Observed glycogen accumulation in muscle tissue. 2. Lysosome discovery and enzyme deficiency. Christian de Duve discovered lysosomes in 1955. Henri Gihers realized lysosomal enzyme deficiency, alpha-glucosidase, caused Pompe disease symptoms in 1965. 3. Enzyme treatment development. Dutch scientists Arnold Russe and Ans van der Ploeg improved enzyme activity in mice muscles in the 1990s. Dr. Huan Song Chen showed enzyme effectiveness in treating Pompe disease in quails in 1998. 4. Clinical trials and myozyme. Clinical trials started in 1999. Myozyme, produced by Genzyme Corps, became an approved treatment. Funding from organizations like the Muscular Dystrophy Association and International Pompe Association. 5. John Crowley's involvement. John Crowley, whose children had Pompe disease, joined Novozyme in 1999. Novozyme was acquired by Genzyme in 2001. 6. Gene therapy and recent developments. Gene therapy development aims to stimulate alpha-glucosidase production. In 2021, successful in utero infusions treated a fetus with Pompe disease. There are 3 types of Pompe disease: classic infantile, which appears within a few months of birth; non-classic infantile, which appears at about 1 year of age; and late onset, which appears later in a child's life and can even appear in teen years or adulthood. Symptoms: classic type, non-classic type, late onset type, which includes adult onset. The infantile form typically becomes evident within the first few months of life. Common initial symptoms include cardiomegaly, 92%, hypotonia, 88%, cardiomyopathy, 88%, respiratory distress, 78%, muscle weakness, 63%, feeding difficulties, 57%, and failure to thrive, 50%. Clinical observations include a limp appearance, delayed motor milestones, and feeding challenges. Moderate hepatomegaly may be present. Facial features encompass macroglossia, wide open mouth, wide open eyes, nasal flaring due to respiratory distress, and weak facial muscles. Cardiopulmonary effects manifest as increased respiratory rate, use of accessory muscles for breathing, recurrent chest infections, reduced air entry on the left lower zone due to cardiomegaly, arrhythmias, and signs of heart failure. Late onset form characteristics. The late onset form of the disease differs from the infantile form primarily due to the less pronounced cardiac involvement. Its onset is gradual and progression slower. Though cardiac issues can arise, they are less severe compared to the infantile variant. This form emphasizes skeletal involvement, particularly affecting the lower limbs. Features of late onset. Late onset symptoms encompass impaired cough, recurrent chest infections, hypotonia, progressive muscle weakness, delayed motor milestones, difficulty in swallowing or chewing, and reduced vital capacity. Genetic variation and symptom differences. Genetic deficiencies alone can't fully explain the illness, as even genetically identical individuals like identical twins can exhibit varying symptoms. For instance, one twin might experience pain while the other does not. Muscle deterioration rates can also differ significantly between them. Prognosis based on onset age. Prognosis depends on the age of symptom onset, with a more favorable outlook associated with later onset cases. Autosomal recessive inheritance. The disease follows an autosomal recessive inheritance pattern. This means both parents must contribute a faulty gene for a child to have the disorder. Carriers of one faulty gene are usually not affected. Genetic cause and mutation. The disease is caused by a mutation in the acid alpha-glucosidase gene on chromosome 17 at 17q25.2-q25.3. There are 289 mutations known as of 2010, with 67 non-pathogenic and 197 pathogenic mutations identified. Gene characteristics and protein. The gene spans about 20 kb with 20 exons, where the first is non-coding. The catalytic site domain is interrupted by a 101 BP intron. The gene's promoter is typical of a housekeeping gene with high GC content, 80%, and lacks distinct TATA and CCAAT motifs. Common mutations and enzyme function. Most cases are linked to 3 mutations. The most common mutation in adults is transversion, T to G, disrupting an RNA splicing site. The gene encodes an enzyme called acid alpha-glucosidase, EC32120, which breaks down glycogen, maltose, and isomaltose linkages. Its deficiency leads to glycogen accumulation in lysosomes and cytoplasm, potentially harming cellular function. Early onset form diagnosis. In infants with early onset Pompe disease, symptoms include poor feeding leading to failure to thrive or breathing difficulties. Initial investigations involve chest X-ray, electrocardiogram, and echocardiography. Findings typically include an enlarged heart with non-specific conduction defects. Biochemical tests reveal increased serum creatine kinase, typically tenfold higher, along with lesser elevations of aldolase, aspartate transaminase, alanine transaminase, and lactic dehydrogenase. Diagnosis involves assessing acid alpha-glucosidase activity in skin biopsy, muscle cells, or white blood cells, depending on laboratory capabilities. Late onset form diagnosis. In adults with late-onset Pompe disease, gradual arm and leg weakness and deteriorating respiratory function are common. Electromyography may distinguish Pompe from other causes of limb weakness. Biochemical test results mirror those of the inflatable form, although creatine kinase levels may be normal in some cases. Diagnosis entails estimating enzyme activity in a suitable sample. Supportive therapy. Cardiac and respiratory complications are managed symptomatically. Physical and occupational therapy may benefit some patients. Dietary changes may offer temporary relief, but won't alter the disease's course. Genetic counseling provides families information about future pregnancy risks. Enzyme replacement therapy, ERT. Enzyme replacement therapy, ERT, is an approved treatment for all Pompe patients. Specialist teams, heart doctors, respiratory therapists, neurologists, etc., can treat symptoms and offer supportive care for those with Pompe disease. Enzyme replacement therapy can help improve muscle tone and reduce glycogen storage in individuals with Pompe disease. The following drugs have been approved: L-glucosidase alpha, Myozyme to treat infantile onset Pompe disease, Lumizyme to treat individuals of all ages with Pompe disease, Avalglucosidase alpha NGPT, Nexviazyme for individuals aged 1 and older with late onset Pompe disease. Enzyme replacement therapy, or ERT, is the only type of treatment approved to date for Pompe disease. As the name implies, ERT involves therapeutically administering a working version of the GAA enzyme to replace the enzyme that is dysfunctional in Pompe disease patients. Prognosis of Pompe disease. Prognosis varies based on symptom onset, severity, and individual factors. Infantile onset form without treatment is often lethal. Early treatment is critical. Myozyme, L-glucosidase alpha treatment extends survival and ventilator-free time in infantile onset patients. Early initiation of treatment before 6 months, aided by newborn screening, shows promise in reducing mortality and disability. Antibodies against infused enzyme impact treatment response, immune tolerance therapy improves outcomes. Late Onset Treatment Study, LOTS. LOTS assessed L-glucosidase alpha's safety and efficacy in juvenile and adult Pompe patients. Results showed patients on L-glucosidase alpha increased 6-minute walk test distance by around 25 meters, while placebo groups declined by 3 meters. L-glucosidase alpha group improved percent predicted forced vital capacity by 1.2% compared to a 2.2% decline in placebo. Diet and exercise role. Diet and exercise are increasingly recognized for limiting symptom progression. Emerging evidence suggests appropriate physical activity can manage disease progression. Case studies show positive outcomes such as 70% improvement in 6-minute walk test after 15 weeks of vibration training. Thank you for watching and have a great day.